Hi, my name is Natalie Benet. I'm an assistant professor of pathology and laboratory medicine. I work at Women and Infants Hospital in Providence, Rhode Island, and I'm recording a lecture today on gynecologic cytopathology. This is the first in the series, and today we will start at the beginning of the Bethesda book. My contact information is noted on the slide here. I have a website and a Twitter handle. Please get in touch with me if you have any feedback. Today, we will talk about report elements, adequacy, and non-neoplastic findings, and then at the end, reporting of endometrial cells. So just to start off, the source for this lecture material was mostly the Bethesda system for reporting cervical cytology. It's a book that came out in 2015. The aim of this system is that the terminology must be, number one, clinically relevant, number two, reasonably reproducible and flexible, and number three, reflect the most current understanding of cervical neoplasia. The Bethesda system was convened for the first time in 1988 following a public outcry over quote-unquote pap mills in which specimens were being processed in less than optimal conditions, and I think patient diagnoses were being missed. So the Bethesda criteria really lays out set guidelines and gives the clinicians universal reporting so that they can understand what the pathologists mean by what we say. So each report has a set list of elements, some of which are required. The elements marked with the asterisk are optional. All the rest have to be included in every pap smear. The specimen type, you indicate conventional versus liquid-based versus other. For adequacy, which we'll talk about in detail, you have to tell the clinicians, was it satisfactory or unsatisfactory? And if it's unsatisfactory, you have to tell them why. The general categorization is optional. The broad category you can note is negative or other or epithelial cell abnormality. A lot of people like to do that, especially not only for GYN cytopath, but for others, just so clinicians, when they take a look at the top, it says negative or it says other, so they get an idea sort of like at a first glance. Under interpretation or result, you can note the things here like negative for intraepithelial lesion or malignancy, and then the things that go under that. Other, which is really endometrial cell reporting, epithelial cell abnormalities, which is, squamous and glandular abnormalities, other malignant neoplasms. And then if you do adjunctive testing, especially HPV testing or IHC, some people do, you have to note that in the report. And if you perform computer-assisted interpretation, you have to note which device you used and how you used it. And then for educational notes and comments, some people like to put management recommendations into their reports, and that's all using published guidelines. Now we'll talk about adequacy. So your options are really only three. The specimen is either satisfactory, rejected, or fully evaluated and unsatisfactory. So in satisfactory specimens, the big question that trainees especially should know cold is the cellularity requirements for adequacy for liquid-based and conventional PAPs. This comes up on tests all the time. Also for practicing pathologists, it's good to know these numbers. I don't really see these kinds of specimens as commonly, but an adequate specimen for liquid-based is at least 5,000 well-visualized, preserved squamous or squamous metaplastic cells. Endocervical cells and obscured cells do not count for either kind of prep. For conventional preparations, which some of the trainees might not know what that means, conventional preps, the liquid PAP, you do the swab of the patient's cervix, you suspend it in liquid, and then that's made into a slide. For conventional PAP, you do the swab or the thing that looks like a pipe cleaner, and then at the bedside, the clinician rolls it onto a slide and fixes it right there, and then that's stained by the laboratory. It's much less expensive than the liquid-based prep. It's not really used in the States anymore. Some developing countries still use them all the time, so throughout the Bethesda, they always talk about both preps and the differences in morphology. There's a table in the Bethesda book you can use. I didn't put it in here, but if you get to the point where you're signing out a slide and you don't know, it'll tell you the objective, how many cells you can count, and there's a formula for estimating cellularity on a slide. These are pretty uncommon. CAP survey data shows that The 50th percentile rates for unsat PAPs are about 1, 1.1, and 0.3% for conventional thin prep and SurePath. So SurePath has the lowest rate of unsats, but they're all pretty low. Also, note that in radiated patients, they also often have lower cellularities, so you don't have to hold them to this 5,000 or 8 to 12,000 cellularity requirement quite as rigidly. In the past, they were held to the same standard and then frequently resampled because the clinicians were being told they were unsatisfactory, which led to problems because radiated tissue can be pretty friable and they're a little bit harder to manipulate and sample. Additionally, postmenopausal women with lots of atrophic change and low estrogen states, they can have trouble with cellularity, and then constant resampling of them can also be problematic. But most samples, or samples with less than 2,000 cells, are considered inadequate in most patients by most labs. And the reason for the difference in cellularity requirements between liquid and conventional is that the liquid-based preps are theoretically a more random sampling of the cervix, since you suspend everything and then spin it down. And it's also concentrated versus conventional PAPs. Some labs take or mention that samples close to the 5,000 threshold are borderline or low squamous cellularity. It really just depends on where you practice. Okay, obscuring factors. And I'll just touch on one more thing for adequacy very quickly. The transformation zone was something that in previous iterations of the Bethesda criteria, sampling of the transformation zone was required for an adequate pap smear, with the idea that if you did not sample the transformation zone, which is the area at highest risk for developing of a squamous intraepithelial lesion, it was not getting to the part of the cervix or theoretically high up enough in the cervix to assure an adequate sample. It's no longer required. However, if you see sampling of the transformation zone, i.e. squamous metaplastic cells or endocervical cells, you have to note it. And adequate sampling of the cervical transformation zone is 10 cells, 10 endocervical cells, or squamous metaplastic cells. So it's still, if you see it, you put it in the report, but you don't have to call something inadequate just because it's not there. Now on to obscuring factors. If more than 75% of the cells are obscured on a slide, the specimen should be considered unsatisfactory, assuming that no abnormal cells are noted. If you see abnormal cells, it's never unsat. And if between 50 to 75% of the cells are obscured, you need to note it in the report and note why they're obscured. And it's more common in conventional pap smears than in liquid-based pap smears. So the two interfering substances or obscuring substances are lubricants and excessive blood. Lubricants are a little bit less common. Most clinicians know now that they shouldn't put the lubricant on before they do the PAP. And then excessive blood can be present due to abnormal or pathologic conditions, also just due to menses, and it clogs the filter of the thin prep or SurePath, which can lead to the low cellularity because the cells literally cannot get through onto the slide. A lot of them can be recovered by treating the specimen with glacial acetic acid. This is a paper, the treated and untreated. So untreated on the left, you can see all the blood. It's very red. And then once they treat it, the blood from memory gets lysed. And so then the cells can travel through the filter. And this is just another paper here, the reference, but it's on the left, the A1 to A2 is untreated and treated, and same with B1 to B2. So you can see how much more cellular the specimens become once you lyse that blood and get it out of there. But the other thing I will note as a practicing cytopathologist is that often treating the specimen with GAC, which is what we call glacial acetic acid, sometimes it changes the cellular detail. And so if I'm dealing with an atypical pap smear, or especially one that may be high grade or suspicious for high grade, I always note that some of the cellular detail is obscured due to treatment, and that if I'm concerned, I ask them to resample when the patient is not bleeding, or if I'm, worried about it, I'll say, you need to make sure you follow this patient with colposcopy or something, because sometimes you don't feel like you're on quite a sure footing when you've treated with GAC. So now we'll move on to non-neoplastic findings. The options are, the key thing to note is that the reason that we do Pap smears as pathologists is to screen for squamous cell carcinoma of the cervix and its precursors. So the first thing you want to tell the clinician always is that it's negative for an intraepithelial lesion. And then the reporting of all of these non-neoplastic findings is optional, and it's also not the reason why Pap smears are done. So we do it to report changes, to help management. And we want to make sure if you see something, you report it. So there's lots of different categories. The first are cellular variations and then reactive changes, glandular cells post-hysterectomy. We're going to go through each of these on their own slide. And then finally, organisms. So we'll step through each of these one at a time. The first is the superficial squamous cell. So that's that pink cell at the lower right-hand corner that the big black arrow is pointing to. It's derived from the outer or topmost layer, depending on how you're thinking about on a slide, of the cervix, present during the proliferative phase of the menstrual cycle. It has a highly condensed nucleus, about 10 to 15 micrometers, with abundant cytoplasm, usually eosinophilic cytoplasm. The next cell, the intermediate cell, would be at that mid portion of the epithelium, more predominant in the secretory phase or progestin conditions like pregnancy or hormone treatment. And then these have a larger nucleus with granular chromatin, 35 micrometers in size, with nuclear groove and abundant cytoplasm. And the reason why I put the ruler here is on tests and even in real life, you'll use this intermediate cell to judge the size of other cells. So for low-grade squamous intraepithelial lesion, things like that, you'll want to compare it to an intermediate cell. And they tend to be present on most PAPs, so they're there as a nice ruler for you. The parabasal cell is the final squamous cell. It would be all the way at the bottom. It would be the least mature, not normally present from hormonally mature epithelium, more common in postmenopausal or hormonally treated patients. And it has a large nucleus with granular chromatin. It's larger than that intermediate cell at 50 micrometers with nuclear groove and abundant cytoplasm. And we'll move on to the glandular elements. Endocervical cells can be variable in size. They usually exhibit polarity with the nucleus at one end and the mucinous cytoplasm at the other. Depending on orientation, they can either look like they do in the lower left-hand corner, like a picket fence, or in the lower right-hand corner, like a honeycomb. The nucleus is larger than an intermediate cell at 50 micrometers with a granular nucleus and a small nucleolus. Endometrial cells are spontaneously exfoliated endometrial cells, so not atypical ones, but they can be epithelial or stromal and can be single or in aggregates. They're smaller than endocervical cells. The nucleus has dense chromatin and can have inflammation or apoptotic debris. There's scant cytoplasm and can be vacuolated. The characteristic exodus ball of endometrial cells with a dense aggregate with an outside layer of glandular epithelium. This is a slide of an additional normal element, a metaplastic squamous cell, which can show a range of appearances from parabasal-like cells to those approximately the appearance of an intermediate cell. But they should have smooth nuclear contours. This is important when you're judging these versus an atypical diagnosis. And the nucleus should be about 50 micrometers. The main differential diagnosis includes high-grade squamous intraepithelial lesion, which can be a difficult distinction. So now we'll get to another normal element, which is tubal metaplasia. This is a metaplastic phenomenon, normal phenomenon, where endocervical epithelium recapitulates tubal epithelium. It happens in normal endocervix, especially as you climb up toward the lower uterine segment. The key is to look for cilia, which in this photo you can see at the top left-hand corner. The nuclei in these cells are round to oval and may be enlarged, pleomorphic, and often hygrochromatic. They can have high nuclear to cytoplasmic ratios, vacuolization of the cytoplasm, and the differential diagnosis includes atypical glandular cells. Another normal element is atrophy. These cells show a flat monolayer of parabasal-like cells with preserved nuclear polarity and little nuclear overlap. They can have a slight increase in nuclear to cytoplasmic ratios. The chromatin is evenly distributed and the nuclear contours are even. Sometimes they present with stripped nuclei, and they can have background that resembles diathesis, which is the inflammatory exudate with basophilic granular debris you see in some tumor conditions. Another thing I'm just going to note one more thing about atrophy. It can be present in a variety of degrees. So some patients will be completely atrophic. Some patients will have some changes of atrophy intermixed with other cells. You can sometimes get giant cells in atrophy. And sometimes in the postpartum state, you can have something that looks a lot like atrophy with all those parabasal cells. The next thing is reactive or reparative cellular changes. There's several different kinds of reactive and reparative cellular changes. The most common, or the sort of classic repair, is associated with inflammation. This shows nuclear enlargement, non-overlapping nuclei. Bi- and multinucleation is possible with nuclear outlines, once again, that are smooth and round, a uniform chromatin, and hyperchromatic and vesicular nuclei. There's a prominent single or multiple nuclei are possible, and there's well-defined cytoplasmic boundaries. In general, it can be associated with inflammation, physical or chemical trauma, and radiation, but like I said, the most common is associated with inflammation, and this is quote-unquote typical repair, like I said. And reactive changes can involve all different kinds, like glandular or squamous epithelium. If you see single cells, irregular nuclei, irregular chromatin, or variation in the size and shape of nucleoli, the repair is atypical and shouldn't be put in this category. And then the classic presentation that for test-taking purposes and in real life is of a streaming look. So they sort of look like they're tethered on both ends and they're being pulled like a school of fish. Classic appearance. So the next kind of reactive repair is associated with radiation. This, like other areas of the body, is associated with that have radiation effect, is an increase in cell size without an increase in the nuclear to cytoplasmic ratio. So they both increase, not just the nucleus. Bizarre shapes are possible. Like in this photo, you can have multinucleated cells or binucleated cells. Mild nuclear hyperchromasia is possible, and cytoplasmic vacuolization is also possible, like noted in this photo. In general, radiation change resolves within 6 months. However, in some patients, it persists. The trouble with these PAPs is a lot of times these patients have a history of cancer, obviously. And so you're looking at very bizarre cells. It's always nice when they show these classic features, but you don't want to overinterpret radiation change as malignancy. You also don't want to miss malignancy in a patient who's been radiated. So sticking with these classic features is helpful. The next kind of reactive or reparative cellular change is that associated with an intrauterine device. The reactive cells may be either endometrial or endocervical in origin, but the amount of cytoplasm can vary. There are frequently large vacuoles, which create a signet ring-like appearance, so they can be pretty alarming. They can have nucleoli. Sometimes they're accompanied by actinomyces. And the trouble I run into with signing out these IUD patients is sometimes you don't know if they have an IUD. A lot of times you do, but sometimes you don't. So when you see these atypical cells and you think it's probably an IUD, you just have to use your clinical judgment on, contacting the provider to find out if that's in the history, or if you're worried enough about them and you think it might be something, you can call them atypical. But if you know and that it all fits nicely together, you can know that it's nothing alarming. You can call it reparative. I just wanted to mention glandular cell status post-hysterectomy. So I would say, a lot of patients who have hysterectomies have hysterectomies for a very common kind of gynecologic malignancy, which is endometrial cancer. And most endometrial cancers are gland forming. So if you have a pap smear in a patient who's had a hysterectomy and now you're seeing glandular cells, you want to dive into the patient's history and find out why that patient had a hysterectomy. Some patients have hysterectomies for leiomyomas. But either way, if the entire cervix and uterus are gone and you're seeing glandular cells in a pap smear, that can be concerning. There are physiologic reasons why you can have glands in a patient who no longer has a cervix. There are rests sort of in the areas around the vagina that can have gland-forming cells, but you should always mention it. And then look closely to make sure that they're not atypical. Even if they're not atypical, I usually note this. And I'm very careful to note, especially if I don't know the patient's history and I have no way of finding it out, that I'm concerned and that they need to work this up. The other thing that happens sometimes is patients have supracervical hysterectomies, but they don't tell you that it's supracervical. They just tell you it's a hysterectomy. So this is a good time for clinical history, which we know as pathologists we don't always get. Just be careful. It can also be hard if you have a tray full of paps and you're looking through them to make sure you're looking at the location. And if it's a vaginal pap smear, that's a good key that the patient no longer has a uterus, because they're always labeled as cervix, obviously, if they still have one. So Trichomonas is our first organism, and these can be kind of hard to find. You can see on the slide here that it's indicated with an arrow. It's a pear-shaped, oval to round, cyanophilic organism ranging in area from 15 to 30 micrometers. It shows pale vesicular, eccentrically located nucleus with eosinophilic cytoplasmic granules, sometimes flagella, and can be accompanied by Leptothrix species, which I'll show you later on. And it may show associated change in the squamous cells, including perinuclear halos or 3D clusters of neutrophils. So if you see those changes in the squamous cells, that's also a good time to start looking for Trick. And then another time is whenever you see abundant acute inflammation. That's a good key. So here is another image of Trichomonas vaginalis. You can see how hard they are to see in that left-hand picture. They almost look like debris. And then on the right-hand side are those perinuclear squamous changes in the squamous epithelium. And then this is an image of Leptothrix, which you can see in the background. They're those thin filamentous organisms, and don't mistake them for Candida hyphae. So the next organism is Candida species, and these can be present as budding yeast plus or minus pseudohyphae, and they lack septations. And the groups of squamous cells are speared often by the pseudohyphae, which is present in this image. And I put a picture of a kebab at the bottom because we call them shish kebabs. And you can see how they sort of almost seem to be collecting along that. And the arrow points to the pseudohyphae. Here is another image of a pseudohyphae on the upper right-hand corner. And then this patient also has lactobacillus on the squamous cells, which is a normal finding, normal flora. And then another candidal species that's possible is Candida glabrata, and these form only budding round yeast with no hyphae. That's a good test question because it's still Candida. It's just not it's not the typical kind, Candida albicans. Okay, and then we also report shift in flora suggestive of bacterial vaginosis, which are individual squamous cells covered by coccobacilli, and we call these clue cells. The lactobacilli, which I mentioned in the prior slide, are usually absent. They can be associated with a clinical diagnosis of vaginosis, but not necessarily. The next organism is Actinomyces species. These are associated with the of an intrauterine device, not necessarily clinically significant. They don't necessarily, for example, have to take out the IUD. And these thin bacterial filaments clump together and form these sort of cotton ball-like structures. You can tell, obviously in pathology, we like naming everything after something else. So I put the picture of the cotton balls there to remind you. The next organism is herpes simplex. The nuclei have the characteristic ground glass appearance due to viral particles with enhancement of the membrane due to margination of the chromatin with intranuclear inclusions, that should say Cowdery bodies, and then multinucleated, sometimes epithelial cells with molded nuclei. So that's all the classic features of herpes simplex. And then cellular changes consistent with cytomegalovirus. You see cellular and nuclear enlargement with large eosinophilic intranuclear viral inclusions with prominent halos, usually noted in immunocompromised patients. So our final topic today is reporting of endometrial cells. This is a normal finding in premenopausal patients, and it's commonly seen in menstrual and proliferative phases. It's considered abnormal in postmenopausal patients. Most patients with symptoms of endometrial bleeding most patients with abnormal uterine findings, which would hyperplasia or endometrial cancer, will present with bleeding. Some of these patients are actually asymptomatic and present on pap smear. So reporting is recommended in postmenopausal patients. However, this information is not typically noted for the lab. We don't really know when a patient is menopausal. Sometimes patients don't know if they're menopausal or perimenopausal. So back in the other iteration of the Bethesda, the cutoff was 40. This resulted in a lot of reporting of this finding. So anyone older than 40, you had to report endometrial cells, and some clinicians, especially non-gynecologists who do pap smears, were becoming sort of confused or spending a lot of time following up on these. So they moved the age to 45 in this current edition. And this only applies to non-atypical endometrial cells. We'll cover atypical glandular cells in a separate lecture, but basically you have to report any endometrial cells in anyone over the age of 45, with the idea that most clinicians know their patients well enough that if you report it on a 46-year-old who's still menstruating, they just discount that and go on about their lives if that's the only finding. But say a patient is postmenopausal and you report it and the clinician knows that it's abnormal, then they can do some endometrial sampling to rule out some sort of underlying pathology. So this is the topics that we covered today. I plan to do other lectures in this series, and if you have any feedback, I welcome it. This is my website, which has feedback forms, and also you can tweet at me. And I want to say a special thank you to the residents at Rhode Island Hospital. We are distance learning now because of the coronavirus, and it would be much more fun to give this lecture to you in person and gesticulate wildly so that you could learn all about how exciting cytopathology is. But for now, this will have to do, and I hope the flexibility of doing these at your own pace will be nice, and please let me know if you have any questions. Thank you.